thought I would talk to you about acute liver failure because it's one of those important things that, everybody needs to know about. So no disclosures. I'm not important enough for that. So through the talk, I want to take you through defining acute liver failure and discussing the definition in contrast with somebody with cirrhosis who might have decompensated disease. Go over the common causes and clinical features of ALF, discuss the initial workup and diagnostic approach, go through some initial management, and then a small word about liver transplantation for ALF. So I'll start with a case, and this happened when I was in service about a month ago. So I was on call, and I got called about a 41-year-old female who presented to the hospital in Southern Maryland with altered mental status and fatigue. No significant past medical history of liver disease, but she does have a history of obesity, diabetes, hypertension, past surgical history of gastric bypass, which was revised in 2024, and diverticulitis. She noticed that she was feeling fatigued a few weeks ago and then suddenly developed more abdominal symptoms, abdominal pain, nausea, and vomiting, diffuse arthralgias. And then husband noticed that she's usually pretty sharp, and she was getting a little confused. So she was brought to the hospital, and this is a local hospital. No significant prescribed medications. She was taking some Tylenol, 1 tablet as needed for the last week or so. About 6 weeks ago, she got prescribed Augmentin, no oral medications or supplements, no significant alcohol use, no drug use, no tattoos, transfusions, or other risk factors for liver disease, no family history of liver disease. So when she was admitted, you can see her vitals. She was a little tachycardic. Looking at her labs, the AST and ALT were a little elevated. Bilirubin was significantly elevated, and so was INR. So that was concerning. Initial exam there, they reported that she was ANO times 3, but a little slow to answer questions. They admitted her to the ICU. She got fluids, mental status improved, and they initially were very concerned about Budd-Chiari. So they got an ultrasound duplex. That was their leading differential, which did not really show Budd-Chiari, but subsequent CT scan, including looking at the hepatic vein, also did not show any clot. It did show some hepatic steatosis. Transferred to the IMC there, where the GI doctor there decided to call us requesting transfer, and we did. So she was accepted to hepatology service overnight to the IMC because that's where she was there. I went off service at that point, but I was looking through, and she was admitted at around 4 a.m. Mental status was normal, documented normal. Vitals were okay. Blood pressure was fine. Seen by the team early in the morning because she came in for significant acute liver injury. We sent off all the workup that we usually do, the infectious disease, serological workup, requested imaging, and then they ordered an urgent liver biopsy. These are the initial labs when she got here. The bilirubin is still pretty elevated. Transaminases are elevated. And you can see creatinine also slightly elevated. During the course of the day, I was following her clinical course. Mental status worsened, and she became hypotensive. Moved to the ICU, intubated. The labs, you can see, got worse. Lactate was elevated. They checked an ammonia level, which was high. They did an arterial blood gas. She was acidemic. Chest X-ray showed pleural effusions. Ultrasound, again, hepatic steatosis. She did have a new PE with some right heart strain. Fluid resuscitation, antibiotics, pressors. So she was moved to the ICU. Some of the workup came back. As you can see, ceruloplasmin is a little low. NT-proBNP is a little high. And this is over the course of the day or days. I'm just doing that in retrospect. ANA was elevated. SMA was okay. AMA negative. Echo didn't really show any valvular disease initially. CT brain was done, which was negative for cerebral edema. She was eventually listed for liver transplantation. Her liver biopsy actually did come back positive, and it showed severe active hepatitis with lobular disarray. There were some eosinophils, plasma cells, rule out autoimmune hepatitis versus drug. There was already some necrosis on the biopsy. The steatohepatitis, I mean, she did have risk factors, but it was fairly mild. And she did not have cirrhosis per se, but there was, because of the inflammation and the necrosis, they couldn't make a determination. So she wasn't really cirrhotic. So I'll come back to her final outcome at the end. I want to talk about acute liver failure because that was the concern with this lady. Acute liver failure is defined as rapidly progressive liver dysfunction in a patient without any known evidence of cirrhosis or chronic liver disease. The timeline is actually pretty generous. It's evolving liver dysfunction over a course of about 26 weeks. It involves severe acute liver injury. The hallmark of acute liver failure is hepatic encephalopathy and coagulopathy. And often the coagulopathy, the INR is more than 1.5. The hepatic encephalopathy can be subtle, but it's one of the hallmarks. There are about 2,000 to 3,000 cases of acute liver failure in a year here in the United States. You can subclassify ALF, which can kind of give you an idea about the etiology. So hyperacute are things that happen very, very quickly. And the most common one that we are all familiar with is acetaminophen or Tylenol. But acute viral hepatitis like hepatitis A, hepatitis E can do that as well. More of the acute over 4 weeks or so are things like hepatitis B, which is thankfully rare here. The subacute are the ones that can take, longer, up to a few weeks or more than a month to a couple months. That includes the general non-acetaminophen-induced causes of acute liver failure, things like autoimmune hepatitis, and some of the other conditions. It is important to contrast acute liver failure with decompensation in a patient with cirrhosis. We generally deem that decompensated cirrhosis or acute on chronic liver failure or decompensation, and that is usually worsening synthetic dysfunction in a patient with a known history of cirrhosis, which includes severe inflammation. So AST/ALT might be elevated, bilirubin might be elevated, they may have jaundice, coagulopathy, all the things, plus or minus hepatic encephalopathy. The difference is in those cases, we use a MELD score for prognosis as opposed to more urgently thinking about transplant. One thing I want to point out is some patients can have cirrhosis even at the time of presentation in a more acute setting and still qualify for the urgent priority for liver transplantation. And that includes things like Budd-Chiari, acute presentation of Wilson disease, vertically transmitted hepatitis B, all those things, and autoimmune hepatitis with the first presentation. They may already have established fibrosis or cirrhosis even, but those can still qualify for urgent listing points. So the etiologies of acute liver failure are varied. As you can see, we can broadly divide them into viral hepatitis, which is, not as common here, but it can be. Drugs, and acetaminophen is the most common cause here. Vascular complications, which can be pretty devastating. Things like Budd-Chiari, which is outflow obstruction. Toxins, boards love mushroom poisoning. I have yet to see one, but it's one of those things that can certainly cause it. And then other things like autoimmune disease, Wilson disease, pregnancy-specific conditions. And the etiologies of acute liver failure actually vary if you look around the world. So if you look at United States, acetaminophen is the most common. The other ones are relatively rare. Now, if you go over to India or Bangladesh, you'll see more viral hepatitis. So where you are in the world can actually help narrow that differential a little bit. So what happens in acute liver failure? There is massive hepatocyte necrosis with loss of metabolic and synthetic functions. There's toxin buildup. Primarily ammonia is the more devastating one, which causes astrocyte swelling. It causes cerebral edema, and ultimately, unchecked, can cause brain herniation and death. There's usually a multi-organ failure with systemic inflammation. And if untreated, overall, the mortality could be very high as 30% on average. It's important to note that the clinical features can actually be fairly subtle, especially in early stages. So fatigue, nausea, anorexia, kind of like what our patient had. Right upper quadrant pain can develop. Jaundice, by the time patients have jaundice, they have significant dysfunction. Confusion is generally a late symptom. Coagulopathy, organ failure, death, those are usually in the latter half of the natural progression. Any questions so far? Okay. I think in the interest of time, I can take questions at the end, but you could also email me. I want to go over some specific etiologies of acute liver failure, and acetaminophen is the most common one, like I mentioned. So most common in the United States and Western countries, about 56,000 ER visits, 2,600 hospitalizations, and about 500 deaths annually in the US. A lot of times, about 50% of the time, I want to say it can be unintentional. There are certainly intentional acetamin overdoses, but if you look at a lot of the data, 48 to 50% is unintentional. And sometimes it could be what we deem a therapeutic misadventure, in which case, patients just don't know. It's not like they're trying to harm themselves. They take increasing levels of Tylenol or acetaminophen without knowing. Organ injury generally is dose dependent. And if you look at, how much in somebody without any history of liver disease, generally you start seeing liver issues after 7.5 to 10 grams in 24 hours of Tylenol. That being said, you got to be careful. So patients with liver disease or any other issues, and specifically patients with cirrhosis, have a much lower threshold. So in cirrhosis, when we counsel patients, we say, do not exceed 2,000 milligrams of all acetaminophen containing things. And there's a lot of things that have Tylenol or acetaminophen that patients don't even think about. So the dose can be lower for harm. It can and does cause renal injury too. And a lot of times for Tylenol overdoses, the renal injury can be apparent in a day or two, but also can progressively get worse before getting better. Symptoms can be delayed. So initial symptoms might not be that bad. Fatigue, nausea, more stomach upset. And then as time goes on, within 1 to 3 days, they may have emesis, right upper quadrant pain, start developing things like hypotension. From about 3 to 4 days, that's when the liver dysfunction and renal dysfunction becomes more apparent, and they get lots sicker. So things like coagulopathy, encephalopathy, may have reappearance of GI symptoms and get really sick. If you survive that stage after about 4 days or so, you can have recovery. And about 60 to 70% of patients can recover, but about 30% can die. So it can be pretty devastating. So this looked at the characteristics of acetaminophen overdose, and at the bottom, I wanted to highlight that in this, I think there were about, I want to say 600 patients, but I don't have that up the top of my head, that they looked at. This was a registry. About 65% survived without transplant. And if you look at the overdose type, about 50% was unintentional. So Tylenol can certainly cause pretty significant injury, and there's a big percentage, like 35 is a lot, that actually do not survive without any intervention. So how does Tylenol cause liver injury? So typically, when we ingest acetaminophen, it's metabolized in the liver, and there's glucuronidation and sulfuration, and it is metabolized into non-toxic metabolites. There is a cytochrome P450 based metabolism into this intermediate product called NAPQI. That is further metabolized using glutathione into safer mercaptate and cysteine compounds. Those are renally excreted. So if things are completely normal, you ingest Tylenol, it's metabolized. There's a small portion that could be toxic or hepatotoxic, uses glutathione, and even that is made inert. What happens with a significant Tylenol overdose is that system gets overwhelmed. So you start developing more of the toxic metabolite that depletes the glutathione. And when that does, this NAPQI actually starts binding to the hepatocytes and causes necrosis, massive hepatic necrosis. The treatment, before we go on treatment, alcohol can actually potentiate this injury, and that's why sometimes the thresholds are lower, and that's because it increases the cytochrome P450 enzyme activity, so more is shunted towards making these toxic metabolites. Also causes glutathione depletion, and these metabolites then bind to the hepatocytes, and they cause local necrosis. Once it does, it's irreversible typically. So in alcohol, patients who consume excess alcohol, the threshold for acetaminophen-induced liver injury might be lower. Where N-acetylcysteine comes in is it depletes the glutathione, so there's increased metabolism of this toxic metabolite into the more renally excreted benign forms. It also prevents the aggregation of NAPQI to hepatic macromolecules. So it facilitates the removal of this toxic metabolite, and it depletes the glutathione, which is initially depleted. N-acetylcysteine is very effective. So in terms of acetaminophen overdose, what to do? If the time of ingestion is known and reliable, which can be a challenge, and it's within 4 hours, activated charcoal can be used. If the time is unknown, or if it has been more than 4 hours, for example, if there's AST and ALT elevation with unknown exposure time, or if it's been more than 4 hours, go ahead and give N-acetylcysteine. There's no harm. It's about 100% efficacious within 8 hours, and then as time goes on, the efficacy goes down. If you don't know, or if you know the time of Tylenol ingestion, you can check the concentration and use a nomogram. I'm sure you've seen this for your boards, the Rumack-Matthew nomogram. And if it's above the threshold, you can use N-acetylcysteine. What I'll say practically is if you strongly suspect acetaminophen overdose and patients have acute liver injury, I mean, unless there's any major contraindication, for example, volume or something, I don't think you'll do any harm, at least initially, starting N-acetylcysteine. There have been studies looking at N-acetylcysteine in even non-acetaminophen acute liver failure, and this is showing N-acetylcysteine versus placebo and grade 1 to 2 encephalopathy and 3 and 4. But overall, the left one shows overall survival and the right one shows transplant-free survival. It wasn't that great. I think there was some benefit to younger patients in the study in younger patients less than 25, or if the etiology was acetaminophen. The way I think about it is if you're on the fence, if the transaminases are really elevated, there may or may not have been acetaminophen exposure. And there's no concern with, excess volume with acetylcysteine. I mean, you can always just start it and then give us a call and we can help. Some of the other causes of acute liver failure besides acetaminophen, so drug-induced liver injury or DILI, can cause liver injury as well. This is more of the subacute typically. This doesn't usually cause acute or hyperacute liver injury. It's a diagnosis of exclusion. That's why I think it's very important to take a careful history. Herbal medications, supplements, antibiotics, and not just antibiotics last week, antibiotics in the last 8 to 12 weeks can be helpful. Antifungal medicines, epileptics, TB meds, NSAIDs. In general, for drug-induced liver injury, steroid treatment is not very helpful. It can be helpful if there is stress or if there is an autoimmune reaction. And a lot of times what we do is we do a liver biopsy and look for an inflammatory component. And if there is an inflammatory component, we could try steroids, but that's a decision, that we make looking at the whole data. Autoimmune hepatitis can cause significant acute liver injury and sometimes acute liver failure as well. Autoantibodies can be suggestive, but they're not 100%. Patients can have autoimmune-like features without autoantibodies being positive. So we do send them. We do send things like IgG, SMA, soluble liver antigen that can help. Other autoimmune diseases can help when you're taking a history. So if somebody has, other conditions like lupus, rheumatoid arthritis, thyroid problems, vitiligo coming in with, possible autoimmune liver disease, it just increases your likelihood in the differential, but it's still important to think about everything. Liver biopsy can be considered if safe. So a lot of times in acute liver failure specifically, we don't do liver biopsy. We instead just evaluate them for transplant. If it's not safe, go ahead and evaluate for transplant. And a lot of times for autoimmune liver disease, by the time they come in very, very sick in ALF, the steroids are not going to help. It's usually a new liver is what they need, and they can be listed urgently. Viral hepatitis are less common here. So hepatitis B, only about 8% of ALF cases here. It is important to note in your day-to-day practice, you will see this, the hepatitis B core antibody positivity in patients who otherwise don't have active hepatitis B. If they're going to get chemotherapy or B-cell depleting therapy like rituximab, do use prophylaxis because that can cause reactivation. Remember, hepatitis B is a DNA virus, and it can integrate into the hepatocytes, as opposed to hepatitis C, which usually doesn't cause long-term problems after you treat it. Hepatitis A, only about 4%, but it definitely can. I remember a few years ago, I want to say about 3 or 4 years ago, when I was at Hopkins, we had a whole slew of patients in Baltimore come in with acute hepatitis A. And I think 1 or 2 actually did require transplant. So, certainly when you're sending out labs, a total hepatitis A total antibody would pick up both, usually the IgG and IgM. But if you're looking for acute exposure, an acute hepatitis panel and an IgM can be helpful. Hepatitis C rarely causes acute liver failure. There are some cases where it can cause pretty significant injury, and those are usually patients, post-transplant patients that we see, that get hepatitis C or have hepatitis C that's untreated or get an organ with hepatitis C. Hepatitis E is a rare cause here, but overall, it can, in the other parts of the world, it can be a big component of acute liver failure, and the outcomes are worse if it occurs in pregnancy. That being said, I have picked up a few hepatitis E's, not necessarily acute liver failure, but I think we do check it sometimes. HSV and VZV are typically in immunosuppressed patients, not immunocompetent patients. Not everybody has the classic symptoms, so not everybody will have a skin rash. Patients can appear very, very sick. Certainly, HSV hepatitis can be fatal very quickly. So I think in these patients, if there is a concern that they may have HSV, using acyclovir, which we'll talk about a little bit in a few slides, empirically, until the PCR comes back positive, you could certainly do that. Fulmin and Wilson is typically in young patients. Seen a couple, it's not very common, but when it does, it can be pretty devastating pretty quickly. KF rings are usually seen on slit lamp examination, Kaiser-Fleischer rings. Ceruloplasmin can be low, but since ceruloplasmin is an acute phase reactant, sometimes it could be falsely normal or low normal. When they're sick enough to have acute liver failure, some of the things that can clue you in are typically things like indirect hyperbilirubinemia because of a Coombs negative hemolytic anemia. You can calculate the bilirubin to alkaline phosphatase ratio, and it's typically more than 2. The confirmation is typically 24-hour urine copper. Sometimes may not have time for that. Liver transplant is the only definitive treatment for an acute Wilson or acute Wilson disease causing acute liver failure. No real role for chelation therapy at that point, if they're that sick. So those are some of the common causes of acute liver failure. Some more practical things. What should some of the initial workup be? A good history can be very helpful. Any history of cirrhosis, because if they have known cirrhosis, barring those 2 or 3 conditions, that kind of changes things a little bit. Risk factors for chronic liver disease: alcohol, which is very common, as you all know, drug use, acetaminophen use, herbal medications, antibiotics. Are they immunocompromised? Could they be pregnant? Recent travel to areas where other viral hepatitis might be more common. Family history of liver disease, recent tattoos, new sexual partners. Good physical exam can also really help determine if they have signs of chronic liver disease. Do they have ascites, gynecomastia, spider angiomata, caput medusae, which are prominent veins near the umbilicus, palmar erythema? All these are signs of more chronic liver disease, more decompensated. Tender hepatomegaly, that could be acute viral hepatitis or acute hepatitis, splenomegaly. A full neurological exam is very, very important because hepatic encephalopathy is one of the pillars of acute liver failure. It can be pretty subtle. Generally a late manifestation, but I do want to stress the importance of serial exams and assessments. And oftentimes when we consult on patients with suspected acute liver failure, we say at least try to get neuro exams every few hours just to make sure we're not missing subtle signs of encephalopathy. Initial blood work, the basic CBC, CMP, INR. INR could be helpful in determining if there's any worsening synthetic function in addition to the elevated bilirubin. At least every 4 hours if they're relatively stable, and if it's improving, you can increase the interval. Acetaminophen level, lactate could be very helpful. You want to rule out other causes that can cause liver injury, things like infections, pregnancy test if needed. And then there are more specific liver labs. So ABO can help us when we determine or when we're working up for things like transplant, viral hepatitis and acute hepatitis panel. Generally, when patients have significant acute liver injury with transaminases in the thousands, I personally prefer PCRs more than the IgGs and IgMs. And because you can actually catch active infection, and some patients may not actually have antibodies. Autoimmune markers can be helpful. For metabolic and genetic diseases like Wilson, hemochromatosis alpha-1, we send some of those labs as well. One of the things that can help with prognostication in acute liver failure is ammonia, and it can actually be helpful if it's sent correctly. So usually ammonia, we see patients in the ER, they have a history of cirrhosis, ER doc sends an ammonia level, and then you go see the patient and they're very confused with hepatic encephalopathy. That's not the time to measure ammonia. But for somebody with no evidence of prior liver disease, an ammonia level could be very beneficial, provided it is collected or sent correctly. An arterial sample is the best. It should be put on ice to minimize the in vitro production of ammonia and sent to the lab as soon as possible. Very rarely is this done correctly, but looking at ammonia, arterial ammonia levels less than 75 micromole per liter, the risk of cerebral edema in a patient with acute liver failure is actually fairly low. Levels more than 100, there can be risk of cerebral edema, and levels more than 200 actually have a much higher risk of brain herniation. I think the recent GI guidelines, the American Association for the Study of Liver Disease, their guidelines are from 2011, but I think the GI Society guidelines came out in 2023, and they actually recommend early dialysis to remove ammonia if patients have grade 2 encephalopathy or higher. So this is just showing that visually. When the ammonia level is around 75 or lower, there's a low risk of advanced hepatic encephalopathy. And then when the ammonia level is more than 200, this is looking at intracranial hypertension. The risk of intracranial hypertension is higher. Imaging studies, ideally in these patients, we like to have cross-sectional imaging for a multitude of reasons. It can show us cirrhosis, it can show us venous anatomy, arterial anatomy for mostly surgical planning. It can rule out any clots, etc. But a lot of times that's not feasible. And if that's not feasible, at least an ultrasound, typically with Dopplers, to rule out things like Budd-Chiari or any thrombosis could be helpful. If there is any concern for hepatic encephalopathy, if you're not sure if it's subtle, you could get brain CT. In later stages, it's more apparent on a CT when there's like ventricular defacement or something. But at least to rule out hemorrhage, initially in somebody who's coming in altered, a non-contrast brain CT can be helpful. And then for true ALF, liver biopsy is rarely needed. Okay. Moving on to initial management. So ALF causes multi-organ dysfunction, and it can affect multiple different things. So we talked about encephalopathy. It causes hepatic encephalopathy, cerebral edema, intracranial hypertension, but it can affect different organs like the kidneys. Frequently, patients develop AKI and renal failure. It can include increased SIRS and inflammatory response. Patients can develop respiratory distress, of course, liver issues. Pancreatitis can be seen as well. So I guess the initial management is mitigating some of these things that happen in acute liver failure while trying to work the patients up for more definitive therapy, which is a liver transplant. We do have some prognostic models. So the King's College criteria is the most commonly used and the oldest, and it can tell you how likely patients are likely to survive without a liver transplant. And if they meet some of these criteria, they actually have a much higher mortality without transplant, and they should be evaluated for transplant as soon as possible. MELD score can be helpful as well. So if you look at acetaminophen, so ALF criteria says that if patients are acidemic despite resuscitation and they have high lactate or three of the following criteria, HE more than grade 3, creatinine being elevated, INR is elevated, they're less likely to have spontaneous recovery, and you should consider transplant. For non-acetaminophen, INR more than 6.5 or 3 out of 5 of the following criteria. Indeterminate etiology, young or more than 40 years of age, interval to jaundice, from jaundice to encephalopathy, more than 7 days, bilirubin more than 17.5, and INR more than 3.5. And you can look it up. You don't need to memorize any of this. So in terms of what to do, in terms of general support, you have to balance doing your diagnostic stuff, but also maintaining homeostasis as much as you can. So initially, in terms of diagnostic tests, we talked about cultures, ruling out an infection, imaging studies, echocardiogram, EKG. In terms of monitoring, number one thing I forgot to mention is if you suspect acute liver failure and you feel like it's true acute liver failure, please make sure they're in the appropriate setting. And the appropriate setting is the ICU for these patients. So they need routine monitoring for things like oxygen saturation, vital signs, blood pressure, heart rate. You want to maintain their MAPs. Look at their urinary output because renal injury is common. Neurological status we talked about. With significant acute liver injury, patients can develop hypoglycemia, pretty significant hypoglycemia, and may require glucose infusions. Stress ulcer prophylaxis. We do not generally give products for coagulopathy unless we're doing procedures or there's bleeding. N-acetylcysteine in early stages, consider even in non-acetaminophen cases. And then, we need to have a good way to determine mental status. So if they're otherwise relatively okay, avoid unnecessary sedatives, avoid nephrotoxic and hepatotoxic drugs. So these are some of the organ-specific complications that can happen. Neurological, cerebral edema is the most devastating, which causes cranial hypertension, intracranial hypertension, and death. There can be abnormalities in coagulation and hemostasis with unbalanced hemostasis, thrombocytopenia. Infection risk is higher, so bacterial infections, fungal infections, higher risk of septicemia. Hemodynamic instability is common, and that can lead to things like hyperkinetic syndrome, arrhythmias. In terms of respiratory issues, ARDS, volume overload, metabolic issues, we talked a little bit about hypoglycemia, hyponatremia, hypophosphatemia, hypokalemia, and then renal dysfunction, so toxic and functional. So I want to take a second to talk about the most devastating complication, which is cerebral edema with herniation. I think this is the one that we want to prevent for sure, not that we don't want to prevent the other ones, but this can be the most devastating, causing death. Hepatic encephalopathy, you can grade from grade 1 through 4. Grade 1 hepatic encephalopathy can be pretty subtle, and it usually involves minimal changes in behavior and level of consciousness. Grade 2 encephalopathy is more gross disorientation, drowsiness, possibly asterixis, inappropriate behavior. And the risk of herniation with the earlier stages of encephalopathy is rare. It's not that high. But as we move into more grade 3 and grade 4 encephalopathy, which includes things like marked confusion, incoherent speech, being mostly sleepy, hard to arouse, but you can arouse them, or the most or the highest is grade 4, which is comatose patient, unresponsive to pain, decorticate or decerebrate posturing. I mean, the risk of herniation is very high. So it's a good idea to get a good assessment of their baseline mental status, but also how they're evolving, because it's if patients have normal mental status, but their liver injury is progressing, they can quickly go from normal to 1 to 2 to 3 to 4. So it's a good idea to kind of keep an eye on things. More specific management. So for early grades of encephalopathy, like grade 1 and 2, you want to minimize disruption as much as you can. So quiet environment, minimize agitation, close monitoring in the ICU, avoid sedatives, non-contrast CT head to rule out things like intracranial hypertension. Lactulose is it's variable if people say use it or not. I think you'll find that the surgeons really don't like using lactulose, and the guidelines are also they don't make a very strong recommendation either way. It can be used if patients are able to protect airway, but in my experience, it can cause agitation, and you don't want to cause agitation. Certainly wouldn't recommend putting in an NG tube just to give lactulose in a patient with true acute liver failure. If you feel like transplant is feasible, specifically if you feel like transplant is feasible in the short term, lactulose might not help because it can cause bowel distension, which makes the actual transplant surgery harder for our surgeons. For more advanced encephalopathy, you have to think about intubation. Things like propofol can reduce cerebral blood flow. We don't want to do that, so you got to be careful to maintain the maps when they're getting sedated. Other measures to reduce intracranial pressure, head of bed 30 degrees, minimize suctioning, no Valsalva or agitation. If they are seizing, you can use medication for that. ICP monitoring, it's a rare thing, and that's using a monitor that's surgically implanted in the brain to monitor the pressures. A lot of times, these patients are very coagulopathic, very sick, and if you're thinking about transplant, that's the definitive therapy. If it's devastating injury because of cerebral edema, they're usually not stable enough for transplant. But you could use an intracranial pressure monitor. So the cerebral perfusion pressure, as you know, is mean arterial pressure minus ICP. The goal ICP is less than 20 millimeters mercury, and cerebral perfusion pressure more than 60 millimeter mercury. Overall, it can improve some survival time, the monitoring, but it doesn't have any survival benefit in and of itself. Other things we can use for cerebral edema are things like mannitol, which is typically first line, and you can repeat it a few times. Risks include volume overload, hypernatremia, hyperosmolality. Hypertonic saline can be used, target a sodium level of 145 to 155. And other options include hyperventilation, hypothermia. I think the guidelines go back and forth. It doesn't really help much. But it's one of the things that you can consider. Moving on from neurological issues, infectious risk is high too in acute liver failure. So high risk for bacterial and fungal infection, low threshold for starting antibiotics if you feel like they may have some infection that we're missing. If patients are not responding clinically to broad-spectrum antibiotics, do consider antifungals early on to expand your coverage. And these can always be, we can always de-escalate antifungal coverage. I'm making this point again, if you feel like somebody may have HSV, hepatitis causing ALF, please go ahead and give acyclovir IV until the HSV PCR comes back negative. I have thankfully not seen HSV related acute liver failure so far in my career, and I don't want to, because a lot of times by the time they become where they come to us, it's too late. It's devastating, HSV hepatitis. And, periodic surveillance cultures you could consider, but I think this is a low-grade recommendation. A lot of times in patients with hepatic dysfunction, you'll see that they have coagulopathy. So the conventional markers of coagulation are affected. So certainly INR is something that goes up. They can also have things like DIC because of their sickness. So it's important to monitor this. If a patient with cirrhosis who's on a liver transplant list comes in with a very high INR and is not bleeding, we typically tell the teams to not give vitamin K. And that's because it's part of the MELD score. It increases their risk of, or it increases their chance of getting a transplant, but also INR is not a great measure in patients with cirrhosis. On the other hand, in acute liver failure, we don't go by MELD score for transplantation. So I think if the coagulopathy is bad and you're interfering with things like procedures, you could certainly replete vitamin K. We usually do this subcutaneously or intravenous, not PO. We usually reserve giving blood products for invasive procedures or if absolutely needed. INR is not a great measure, like I mentioned. New studies like thromboelastography can be used to guide treatment decisions in patients. You don't want to unnecessarily transfuse patients and cause hypervolemia. And oftentimes the FFP or the platelets you give, it's not going to make any difference whatsoever. So be careful with over transfusion as well. If patients are hypotensive, which frequently they are, IV fluids plus or minus dextrose, because they are oftentimes hypoglycemic, can help. And then pressors as needed. I think the American guidelines still say norepinephrine first and then vasopressin. Now that we have terlipressin, we can use that as well. Prevent AKI if possible, but a lot of patients do have AKI. 70% of patients with acute liver failure can develop AKI, and 30% require renal replacement therapy. If patients do require renal replacement therapy, the preference is continuous veno-venous hemodialysis. And that's because it causes first they're hypotensive, so they don't tolerate IHD, and you don't want to cause massive swings in their perfusion. And like I mentioned previously, the newer guidelines are recommending that we consider early RRT for ammonia clearance in patients with grade 2 or higher hepatic encephalopathy. And sometimes we do, and I think ICU here has been very accommodating, and nephrology here has been accommodating, and it makes a difference if the ammonia levels are very high. The hemodialysis can help reduce that. Metabolic abnormalities we talked about. The other thing is feeding, if safe to do so. I think enteral, always using the gut is always the best. And we recommend enteral feeding over things like parenteral feeding if possible. So true acute liver failure, and that is acute liver failure or acute liver injury in a patient without any history of cirrhosis or chronic liver disease, which is manifested by synthetic dysfunction plus coagulopathy plus hepatic encephalopathy. It's a medical emergency. And all these patients we should consider for liver transplant. Oftentimes, whether or not they're not a candidate for transplant or not, if a hospital is calling and they don't have transplant facilities, we still bring them over because, we are a transplant center. We see this a lot more. A lot of smaller hospitals just do not have that capacity. So usually we don't say no if some hospital calls us for ALF. Even if they don't end up qualifying for transplant, I think we should still evaluate everybody for appropriateness. So that's gives us a segue into liver transplantation. So I pulled this up from the registry, the Scientific Registry for Transplant Recipients, the SRTR. I pulled this up yesterday, and this is data from 2023 report. And you can see different etiologies of patients who were transplanted in the United States, and alcohol-associated cirrhosis still remains the top indication for liver transplantation. But look at things like MASH. I mean, they're rising as well, and they're a common cause of transplantation. Viral hepatitis has declined, but acute liver failure has remained fairly steady through the years. And the numbers, we don't do a lot of transplants in the country for acute liver failure, but the numbers are fairly steady. So this is from last year's report as well. So for a diagnosis of acute liver failure, comparing 2013 to 2023, 229 to 198 transplants. So about 2% of transplants we do for acute liver failure. And that has remained fairly steady. And when we do consider patients for transplant, they get priority. And I'll talk about the status 1A, which is what this is pointing out, which is also about 2% of transplants. In general, transplant stuff progresses pretty quickly for these patients. If we don't do anything, the median time to death from admission can be as low as a few days. Causes of death are typically neurological, but also multi-organ failure, sepsis, cardiac arrhythmias, arrest, respiratory failure. When we do evaluate people for transplant, we try to get it done as soon as possible. The patient that I presented earlier, I think we listed her for transplant within less than 12 hours. I think everybody saw her and we got her listed, but it still can be a few days. So I think it's good to have that mechanism and that support for everybody. So just to kind of fill everybody in, what happens when we evaluate patients for transplant? It's a multidisciplinary team. I'm just one part of it. I'm a transplant hepatologist on the medical side, but patients are evaluated globally, and that means being evaluated by our transplant surgery colleagues, anesthesia. We look at their echocardiogram, do a cardiac evaluation. Social worker can be very helpful in determining, overall support. And a lot of people, in times of acute liver failure, we try to get everybody to see the patient as quickly as possible. And our fellows are supposed to come in the middle of the night and evaluate the patient, even if it's after hours for these patients, because time can be of the essence. If patients are deemed to be a candidate for transplantation, we meet as a committee, approve them, and then they can be listed. In general, when a patient has cirrhosis and we list them for transplant, we use something called the MELD score, which is the model for end-stage liver disease. And that gives us prognosis and the risk of dying. So the higher the MELD score is, the higher risk of dying, the higher priority. For patients with acute liver failure, truly acute liver failure, we use something called the status 1A, which gives them urgent listing priority. They go on top of all the MELD scores. So according to UNOS, which is the body governing transplant, status 1A is appropriate for a candidate who has a life expectancy less than 7 days without a transplant and has one of the following conditions. And I want to highlight the fulminant liver failure one. So fulminant liver failure without pre-existing liver disease, currently in the ICU, and acute onset of encephalopathy, and at least one of the following criteria: is ventilator dependent, requiring dialysis, and has an INR greater than 2. Notice the slightly different definition here, INR 2 as opposed to 1.5, which we had previously said. So for listing purposes, the INR needs to be a little bit higher. For definition purposes, it's a little bit low. How do these patients do? So 1-year survival, according to some of these studies, is about 80%. And that actually is about the same, maybe slightly lower than our general 1-year survival. If you make it past 1 year, the first year is when most of the complications of transplant happen. The 5-year survival is about 75%, which is about par for all cases of transplantation. Mortality, like with any transplant, is highest early post-transplant. Common causes of death can include things like liver-related issues, non-function, infectious complications, neurological complications, multi-organ failure. This is showing the mortality post-transplant for all causes. And as you can see, 1 year, it's about 90% in general, and ALF patients, about 80 to 85% is what's overall reported. So I want to conclude by saying ALF can be life-threatening. It's very important to identify early. Initial workup can be very important because it can point us to an etiology. Good history, good physical exam, initial lab work and imaging, as I noted there, and then ongoing assessment and monitoring, specifically for neurological decline, because that could be devastating. Acetaminophen is one of the most common causes. Initiate N-acetylcysteine early transfer to transplant center, and early transplant evaluation is crucial, and transplant can be life-saving. So I want to thank you for your time, and thank you for asking me to give this talk, and I'm happy to take any questions.